or do you guys want to lead the conversation?
Well, we'll lead it, but you'll do most of the talking. All right, we're here. We're on the road. We're headed to Cleveland. Here with Dr. P, myself, and then we got
Dr.
world
Hakki.
famous Dr. Tariq here. How are you,
Tariq?
Doing great. How are you guys doing?
So, do you like to be known by Tariq or Dr.? How do you say your last name?
Hakki?
Hakki?
Dr.
That's
Hakki.
right. That's right.
Dr. Hakki is awesome. I mean, he is doing a very prestigious fellowship right now, and then he's going to be going to another city. We'll kind of let him talk about, who he is, where he did his schooling, and where he is now, and what the future holds for him. Dr. Hakki, welcome to the Drive for Men's Health.
Thank you. Yeah, thanks for inviting me. This is a great opportunity. So I'm finishing up my fellowship at Baylor here, and I trained initially in my residency at the University of South Florida in Tampa, and now I'm finishing up at Baylor. So I'm heading to Atlanta, and I'll be working with advanced urology out in the suburbs, northeast suburb. Okay, are you guys coming in there?
Yeah, I can hear you. Can you hear me?
Oh, no, I think I just lost you guys a second ago.
Oh. No, but we can hear you. So, are you excited to move to Atlanta?
I'm excited about it. I'm stoked. It's good to be moving on.
It's good to finally be done and get a real paycheck. I will tell you, it is awesome, and then to be your own boss. So tell us, you want to talk about Peyronie's disease now. Peyronie's disease is something that most people don't really like to talk about or don't even know it's a real disease until they either become sick or things start hurting. So our audience is very general, and they may not know a lot of the urology stuff. So if you don't mind kind of telling us what exactly Peyronie's disease is, that would be awesome.
Yeah, so Peyronie's disease is formation of scar tissue in the erectile tissue of the penis. And this has many theories as to why this occurs, but it causes penile pain and deformity. And what a lot of guys don't know is, this is a problem that's, about 5 to 8% of the male population, but, some men are told that they're okay with watchful waiting. Which is not an okay. And recent studies have shown that 30% of men fail to progress if they have no treatment given to them. So this is definitely a disease that's out there with a lot of stigma, and a lot of men just choose to ignore it and live with it.
Well, so the thing is I get a lot of patients that say, "Oh, I have an angulation," but they don't really have a curvature. So is it normal for men, not talking Peyronie's, to have a bend to the right or the left?
They can have a congenital curve, up, right, left, and even down. But I mean, they can just, as long as it's not affecting the intercourse, and it's something that's always been there and it's not changing, I would advise not doing anything with it, just kind of monitoring it and see if it's causing a lot of distress, then it's something we can bring up and talk about how to manage that.
So when you say patients, so let's say someone has this abnormal curvature, what will you or someone that specializes in this do for them in the office, when they first go see them?
So
do they just crack these things or put you on drugs or something? What is it exactly?
So first of all, you're going to do a good history and physical examination, but many patients will actually come in with photos of the curve, and they can say, "Hey, look, doc, this is what's going on right now," and they'll show you several pictures of the curvature. And then, on top of that, we try to get some questionnaires to give us an idea, of how their erectile function is and how they're overall doing. And then we can do something called a Penile Doppler, an ultrasound, where you cause an artificial erection, and it gives you an idea in the office of how their curve is and what degree of bend and deformity that they have. It gives us a lot of information. There are a couple of questionnaires that are out there, the PDQ and the IIEF, which are some of the questionnaires that some people use.
So what I don't get is, why do you need an ultrasound then? I mean, if you just want to do an artificial erection, how does the ultrasound help the whole process?
So the ultrasound can give you an idea of one, the actual curve, and you can get like a little machine out called a goniometer and get the angulation of the curve. It also tells you, where the plaque is or the scar tissue that the patient has. It also tells you information of how thick it is, and it gives you a general feel of how bad the Peyronie's disease is and how the patient is coping with it, as far as can they penetrate, what angle of degree they have, and how strong their erections are, which is also important in how you're going to treat them.
So when you say treatment, now I remember from residency, it was like 1/3, 1/3, 1/3. 1/3 get better, 1/3 stay the same, 1/3 get worse.
Yeah.
Because you see a lot more of this than I do. And when I get a Peyronie's patient, I send them away. So
you can send them up if you want. Send them north to Atlanta. We don't mind. So that is true. The general mantra: the 1/3 get better, 1/3 stay the same, and 1/3 eventually get worse. But there are two phases to Peyronie's disease. There's an active phase, which lasts 6 to 18 months, where the patients have active inflammation and they complain of penile pain and they have progressing deformity. And then there's the second phase, or the stable, painless plaque phase, where they just kind of live with this deformity. And it's patients that are patients in the active phase. You're not going to do anything other than assessing how they are and starting maybe medical therapies for them. It's the patients that have the continued stable plaque, that we're going to consider for surgical treatment and consider further therapy, but they're not improving on the non-surgical therapies.
So what's the latest with vitamin E? Like, is that still like a sham, or does that really work?
So vitamin E is a scavenger of free radicals, and it's associated with decreasing anti-inflammatory effects seen the penis. However, there's a couple of studies, I think double-blind placebo done in 2007 in Journal of Urology, it showed there was no improvement of vitamin E in the use versus placebo. So, vitamin E is kind of still just more theory rather than actual application. It's the same thing with other medicines like Pataba. Colchicine has been used, but in combination with vitamin E, I think there was a study in BJUI which showed that there was some decrease in pain and early plaque formation when it was administered early.
So it's not. I mean, what is your usual thing? Like when patients come in, what's the first thing that you do for them?
So as far as medical therapy goes, we usually use pentoxifylline, which is a non-specific phosphodiesterase inhibitor. And there have been several studies that look at that decreases the calcium content inside the penis in different rat models. I think Tom Liu did a study in 2011. There's a couple other journal articles showing that pentoxifylline can, when given early, can reduce the effects of the fibrosis in the penis. So usually we give patients pentoxifylline in combination with L-arginine, which has been shown to decrease the overall inflammatory process, because the theory is that this is runaway inflammation that's causing the Peyronie's disease.
Oh, okay. So would you say patients that have like inflammatory disorder, like scleroderma and stuff, are more prone to Peyronie's? Or like
there's a genetic component, but I'm not sure if there's a component there. The elastic tissue of the penis has no blood supply to it. So when you have like these micro stress fractures that cause Peyronie's disease or the scar tissue formation, you have issues clearing out these inflammatory agents. So that's why we give patients anti-inflammatory agents initially.
Okay. Now, what are some of the surgical options? If a patient fails the stuff, I know there's injections that we can give.
Yeah.
I used to give calcium blocker injections, which I think no one does. But I think there's some newer things that, if you don't mind kind of sharing with us.
Yeah, so right now, there's the old mantra of IFN and other injectables like steroids, and those have kind of fallen by the wayside as Xiaflex or the collagenase has kind of come into favor. And that's essentially 2 injections with modeling episodes after that. And this is an inhibitor of collagen buildup, and you inject the plaque, and then you just essentially are recracking the plaque again. And this is noted 30% improvement in the early studies. And this was just recently FDA approved, finishing clinical trials, I think last year, 2 years ago. So we're using a lot more of the XIAFLEX initially. Patients that come in, initially are usually the active phase, and we have to wait for them to kind of get into that stable plaque phase, and we can offer them the XIAFLEX injection.
So you can't do it during the active phase, so you would probably wait.
Yeah.
Oh, wow.
We put them on like vacuum erection therapy along with L-arginine and pentoxifylline. There's another study that's shown PDE5 therapy, or like Cialis, daily Cialis, is also beneficial. That was also noted to decrease scar formation when compared to placebo trials. But usually that's where we start off, and then we'll move to XIAFLEX therapy. We'll discuss the option, and a lot of insurance companies are taking, so it's really a great option for patients these days.
That's pretty neat, man. So surgery, like, I know some of the surgeries are pretty intense. Now, what I always tell my patients is, for Peyronie's, is I can probably do some of these surgeries, but you want to go somewhere where they do this all the time, or someone that's been fellowship trained in this, because I always tell them is, if I'm going to do a surgery, there's a potential of me scarring things, so I may cause this to even get worse, or you may even go through pain. And I've seen some patients that come to me for second opinions that have had surgeries done elsewhere, and I'm like, wow, like, this, it looks kind of rough, because they'll come in like totally bent, like 180 degrees. So I think you have, like, I would say, one shot at this, correct? Like, you guys, where you are right now as a center of excellence, you guys probably see a lot of patients for second opinions as well, correct?
Yeah, we see a fair amount. Usually, if they've passed through the other medicines, a lot of people are still using the topical therapies and the injectable IFN and the older injectable therapies. We're having good results with XIAFLEX, but some patients don't want to have the needle injection. It's quite painful, and they have to have several cycles. So they're having 2 injections, and then they're having a molding event, and they can't have intercourse for a couple of weeks after the injection. But then we talked about surgical therapies, and you kind of have to think of it, are you going to fix the bad side, or are you going to correct the bad side, or are you going to make the good side worse? So what you can do is you can shorten the good side, straightening the penis that way, or you can kind of fix the bad side by removing that piece of elastic tissue in the penis and putting what's called a patch over it. But these are very technically challenging surgeries. So, I would definitely,
since you're an expert at it.
Yeah, definitely go to somebody that's very comfortable doing that surgery, because there's a lot of nerves and blood vessels in that area. They have to make sure that you're able to move appropriately for the surgery. And then there are some patients that have poor erectile function, and they have bad, Peyronie's disease. And then we discuss with them the use of a penile implant, and that comes with its own pitfalls. But overall, we're able to correct those patients and make them within 10 to 15 degrees, of a curve of what they formerly had, and we're able to resolve their erectile dysfunction. So we're able to do a 2-for-1 deal by putting in the penile implant for those patients. That's why the artificial erection and the Doppler is very useful to kind of give us an idea of their overall erectile function. And there's the theory that erectile dysfunction causes Peyronie's disease, because most men, it comes because of penetration or buckling, and they get these microfractures, and that's what causes the scar tissue buildup. But I always try to counsel patients to be very careful, and we give them all the options. Starting off with like the conservative therapy, then going on to traction therapy or the vacuum erection device, and then moving on to XIAFLEX or the injection therapy, and then surgical therapy finally if they've exhausted the other ones or they don't want to undergo the shots.
So most men, the whole goal of the Drive for Men's Health is trying to get guys in to see the physician earlier. When it comes to Peyronie's, it seems like if you start feeling a bend or it hurting, you should go see it. You should try to get treatment during the active phase rather than when it's stabilized, correct? Or is this one case where you want to kind of see what happens?
No, well, there's a 30% chance from the historically that you're going to get better, but going in, getting treatment earlier is better. You can decrease the amount of inflammatory tissue that happens. Studies have shown that you can decrease the amount of plaque buildup, and you can improve the overall, outcome of the patient by giving them early therapy. So I tell men, if you're having, curvature with an erection that's abnormal, it's painful, you're having, those symptoms of curve and being inability to penetrate, get treatment early, because there's things we can do to stabilize this scar tissue, and treat it, and there's a big stigma for this. And I think that, there are other therapies beyond that, that we can do to intervene later on, once everything has kind of stabilized and quieted down. But a lot of guys, we can fix them with just medical therapy and traction therapy before they even get into, the whole so like shots therapy or like the surgical therapy.
Fantastic, Hakki. Well, thank you so much for joining us. Any tidbits on men's health? Because you're about to go to Obesity Central and some, in this states. Actually, I guess where you are right now, there's an epidemic. I guess there's an epidemic all national.
I think it's all in the U.S.
So we want to make sure that we get guys to get in earlier, not just for Peyronie's, but all urologic diseases, actually all medical diseases. And we appreciate you taking the time out of your busy schedule to meet with us today and talk about Peyronie's. And any last words or insights that you'd like to share with us?
Yeah, I can't stress how important it is for men to have a healthy diet and exercise. It's extremely important for cardiovascular, and also for the overall men's health in general and sexual health as well. So, if I can push any of those points home, I definitely would, because it's a very important thing you guys are doing. And I don't think enough guys pay attention to their health, and we wait for things to be too late. In cases like Peyronie's, there are treatments out there. There's no longer the stigma around this. We're trying to become more vocal about men's health, and I really think what you guys are doing is really important.
Well, we appreciate you being a local driver, and you're going to be our local driver now in Atlanta, where you are today. So thank you so much. And one last thing. There was this new toy that you were using. It's like a 3D helmet or something. What is that stuff? Are you going to be doing that in Atlanta?
Yeah, so it's a 3D headset, and basically whenever you're doing microsurgery, only the surgeon can operate in 3D. So what we've done is we basically, Sony's created a 3D headset, so we're able to attach that to the microscope and operate without putting your head to the microscope, and essentially just wearing what you need to operate, which is really kind of handy. You don't have to look into the microscope, adjust the levels. It's kind of cool.
That's awesome, man. Well, we look forward to keeping in touch with you, and definitely follow us at dropformenshealth.com. We live in New York. We're on our way to Cleveland, so we got a long journey ahead of us, and we appreciate your support, Dr. Hakki, and you are awesome. And good luck in your new practice. I guess you're going to be joining very soon, right?
Yeah, I'll be starting in August. I'm really excited, but it's been great just talking to you guys, and I think this is a really important thing that you guys are doing. Thank you for including me on this. It's great.
Thank you, sir. Thank you. And
Thanks
we'll
so
see
much,
you later.
guys. Yeah, take care.
Thanks, bud.
Thank you, Dr. P. Thank you.
Bye.
All right, take care.
Bye.